Yeah, good evening, everyone. I welcome each and every person for the Tuesday's masterclass, which we are conducting since last more than a year now from the Critical Care Department of Yashoda Hospitals in association with IDCCM Hyderabad. Today, what we are going to discuss is on ARDS, which we all know that it is the one of the most important thing when it comes to any form of ICU, and even more important when it comes to the students who are going to appear for exams. To discuss and to moderate, we have two of the stalwarts when it comes to critical care in our country. Dr. J.V. Divatia, sir, is a professor and head Department of Anaesthesia, Critical Care and Pain at Tata Memorial Hospital, Mumbai. He is a president-elect at Indian Society of Anesthesiology. He is past president of Indian Society of Critical Care Medicine, past editor-in-chief, Indian Journal of Anesthesia. There are many, I think, if I'm not wrong, maybe hundreds or thousands of papers in his name, both in critical care and anesthesia. He's one of the teachers we have listened throughout our life. And the next person is Dr. Subramani Kandasamy. He is professor and head surgical ICU at CMC-Vellore. His special interest in trauma, neurocritical care, mechanical ventilation, pharmacokinetics, and fugal innovations in critical care. I welcome you both, sir, and thank you for joining us, taking out time from your busy schedule. And to present this, we have two of our residents, our IDCCM resident, Dr. L Meghana and Spoorti Pujari. So they will be taking us through the case. In between, the questions and all will be asked as usual in any form of exams, the way we go ahead. And I will request each and every attendees who are attending the session today, please post your questions in the Q&A. So we'll be answering those questions whenever it is relevant, or at the end we can discuss all those questions. So feel free to post your questions if there is anything. I'll hand over to Dr. Meghana and Dr. Spoorti, sir. From now onwards, Divatia, sir, and Subramani, sir, will be moderating the session. Thank you.
Good evening, everybody. Myself, Dr. Spoorti.
I'm Dr. Meghana.
So today's topic for case discussion is ARDS. Chief complaints. 37-year-old male software employee by occupation was admitted from emergency room to ICU with the chief complaints of cough since 8 days, fever since 5 days, and breathlessness since 3 days. History of presenting illness. Patient was apparently all right 8 days back, since when he developed cough, which was insidious in onset and gradually progressive, not associated with expectoration, chest pain, no diurnal variation or postural and seasonal variation. History of fever since 5 days, insidious in onset, gradually progressive, continuous, low grade, subsided with medication, not associated with chills and rigors, sweating, headache, or rashes. Shortness of breath since 3 days, insidious in onset, MMRC grade 1, gradually progressed to grade 4, associated with wheeze. No history of orthopnea, PND, syncope, chest pain, or palpitations. Past history. Patient did not have any comorbidities. There was a history of previous hospital admission for COVID-19 pneumonia. Patient required NIV support during the episode, and this was 1 year back. Family history, no similar complaints in the family, no other relevant history. Personal history, patient consumes mixed diet, reduced appetite since few days, disturbed sleep because of shortness of breath, bowel and bladder was regular and normal, smokes 5 to 10 cigarettes per day since 10 years, 5 pack years, occasional alcoholic.
So, are there any significant points in this history you have taken just now?
Sorry, sir.
Can you hear me or?
Yes, sir.
Okay. What are the kind of significant issues in the history you just elicited? You're going to interrupt in between. Sorry if it is going to obstruct the flow of your.
Significant history is cough, fever, and breathlessness, sir, with past history of COVID and requiring hospital admission and requiring NIV. And personal history, he's a smoker and with no other comorbidities and no significant family history, sir.
So do you want to dwell into a little more onto the history because of these two things, and especially COVID and past history of smoking?
Yes.
So
What
pardon.
would you like more on that? This situation? You have a past history of COVID.
Sorry, sir. Subramani, sir, your the audio is not very clear, sir, actually.
Okay.
Can you
No,
go little close?
There's two significant points in the history, the past history of COVID. Would you
Yes.
like to know a bit more? Because the patient has come with respiratory symptoms.
Past history of COVID, whether he has received, whether he was admitted for long time in the hospital, and whether he had received any vaccination for COVID, and whether he has any structural lung disease.
And
Okay.
also whether he was requiring any oxygen support
Post-discharge.
post the discharge, all that.
Okay. All right.
Yes, sir.
Okay, go on, proceed.
So, based on your history, what do you think this patient has?
Sir, he has a lower respiratory tract infection, sir. A probable lower respiratory tract infection because of fever, cough, and breathlessness, and associated wheeze, with no other symptoms suggestive of cardiovascular involvement. At this point of time, we would like to think it as a lower respiratory tract infection.
Okay, so maybe a community-acquired pneumonia. or something.
Community-acquired pneumonia.
Bilateral.
Right, carry on.
Patient took treatment on OPD basis with above complaints. He was not willing for hospital admission, so HRCT chest was done in the outside hospital, which was suggestive of bilateral patchy consolidation. So in view of shortness of worsening of the shortness of breath, he came to our hospital for further management.
So is there anything you want to know as to what happened in the other hospital at this stage?
So actually, he took the treatment on the OPD basis, sir. He was not willing for the in-hospital admission. So he took it on the OPD basis, and OPD basis only they had done the HRCT chest, sir. And
In terms of treatment, so that is investigation. In terms of treatment, do you want to know?
Yeah. Yes,
So
sir.
whether he has taken any antibiotic and antiviral during the OPD visit, or whether he was requiring oxygen during like his saturations during his visit, and whether he required any oxygen support.
Okay. So in terms of the COVID history, I just forgot one point. Post-COVID sequelae, what is the commonest problem you see in post-COVID sequelae?
Pulmonary fibrosis, sir.
Other than that? So what happens when there is fibrosis in the lung?
The complaints of the lung.
Interstitial lung disease.
Anatomically, what happens? Structurally, fibrosis causes traction.
Traction bronchiectasis.
Okay, so that's also important in this situation.
Yes, sir.
Okay, all right. Proceed.
At emergency room, patient was tachypneic, tachycardic, and restless at presentation. His vitals were heart rate was 132 beats per minute, blood pressure was 132 by 84 millimeters of mercury, respiratory rate was 38 cycles per minute, saturation was 75% on room air, and on NRBM mask on 15 liters of oxygen support, his saturation was 85%. ABG was done with 15 liters of oxygen and NRBM mask. The pH was 7.33, PCO2 was 50.9, PO2 60, bicups were 26, lactate 0.86, and PF ratios were 75. Patient was started on NIV support, and all the routine investigations like complete blood picture, renal function test, liver function test, electrolytes, chest X-ray, PT-INR were sent from the ER. Blood culture sensitivity was also sent, and patient was started on empirical antibiotics.
Okay, can I stop you there, please?
Yes, sir.
So what is significant in the blood gas analysis? Yes, you just presented.
Patient has type 2 respiratory failure with hypoxemia and hypercapnia, sir. And there is respiratory acidosis picture, sir.
So is this a acute or a chronic? And how will you decide whether it's an acute or a chronic?
As patient is having a history of cough, breathlessness, and fever, which started since 8 days, I would consider it as chronic only, sir.
Based on the blood gas, can you make that determination? Just looking at the blood gas.
It looks like it's a
Bicarbonate is 26, sir. So
it's look like it's chronic only, sir.
So how much is the CO2 gone up by?
It has increased by 10, sir, and HCO3 has increased by 4, sir.
What is the pH change by?
Yes, sir. There is a there is a mild change, sir, like 0.00.
0.12.
0.1, right? Roughly.
Yes, sir. 0.12. 0.12.
Bicarbonate has not gone up significantly. It's just changed.
Just only 4. Yeah.
So had it been a fully developed chronic respiratory acidosis,
Bicarbonate would have been more, sir,
sir.
more than 26.
how much does a bicarbonate change for 10 change in CO2?
It for every 10 increase, like when it is chronic, it increases by 4, sir. And if it is acute, then it increases by 1.
1 to 2, right? So this is somewhere, this is more acute than chronic, right?
Yes, sir. By APG, yes, sir.
So what does it tell you? So this bicarbonate is the PCO2 is 50.9. Does it tell you give you some information? You're saying it is not chronic, it's something acute.
Yeah.
So if he had, like he's a smoker, but he's not a very heavy smoker.
Yes, sir.
Yes, sir.
He's a fairly young fellow.
Yes, sir.
He doesn't appear to have a chronic COPD.
COPD or emphysema, PCO2.
When someone with an acute pneumonia comes and so what do you expect in someone who comes with a pneumonia, with an acute infection, which causes acute respiratory failure?
We would expect type 1 respiratory failure, sir, but hypercapnia we wouldn't expect without history of COPD or obstructive airway disease like asthma.
So in an acute hypoxic respiratory failure like pneumonia, why is hypoxia more common than hypercarbia? So in other words, what are the mechanisms of hypoxia in patients with pneumonia?
Alveolar infiltration with macrophages and impaired oxygenation, impaired ventilation perfusion, sir, which causes hypoxia.
What sort of impaired ventilation perfusion? What are the different types of ventilation perfusion abnormalities that result in hypoxia? So you've heard of low V by Q ratios?
Yes, sir.
What is low V by Q?
Where the perfusion is more than the oxygen, less than 1. Yes.
What do you mean by shunt?
Shunt. Yes, a shunt is where there is a mixed oxygen mixed blood. So like oxygenation is less than the perfusion. Like there is no match between the perfusion and oxygen.
Oh, so match means what? What is there and what is not there in a shunt? Ventilation is present.
Yes, reduced oxygenation.
So if the alveolus is completely collapsed,
Okay.
but the blood flow is maintained.
Reduced oxygenation and perfusion is maintained, sir.
Venous blood doesn't pick up oxygen and it goes back as venous blood itself, right? So that picks up 0 oxygen.
Yes, sir.
Completely collapsed alveolus. So that is a shunt.
Yes, sir.
And if it is slight partially collapsed, there is some aeration, it picks up less oxygen, right?
Yes, sir.
Those are 2. And what do you mean by hypoventilation? What is hypoventilation?
Hypoventilation happens when there is respiratory muscle weakness, or if the patient is not, when the respiratory rate is less than 14, then it is called hypoventilation, sir. It can happen due to respiratory muscle weakness, or
In case of like any CO2 retention, or when the patient is not very alert. So where
So when do you know there is hypoventilation?
when the respiratory rate is less than 10 to 12 breaths per minute.
there will be hypercapnia and hypoventilation because there will be CO2 retention because of the low respiratory rate, sir.
So if there is high CO2, it tells you it is hypoventilation, right? Then you have to figure out the cause of hypoventilation.
Yes, sir.
So why is this patient hypoventilating with a respiratory rate of 38?
Because of respiratory muscle fatigue, or because of when the respiratory rate goes high, there will be decreased.
There is a decreased exchange of the washout of the CO2, sir, in this patient because of the underlying infection. So there is a reduced gaseous exchange which is happening because of the alveolar collapse, and also because of lung injury.
The point I'm trying to make is when there is reduced gas exchange,
Yes, sir.
oxygenation is badly affected. The CO2 rises because of abnormal gas exchange. It means the gas exchange is terrible.
Yes, sir.
Okay, because otherwise CO2 diffuses much more than oxygen. So
Yes.
oxygenation always suffers. CO2 is usually not very badly affected. But if the CO2 is badly affected, it means the oxygenation is the degree of abnormal gas exchange is horrible.
Yes,
Yes,
sir.
sir.
Or there is respiratory muscle fatigue.
Yes, sir.
Right?
So what are the other situations? So when Dr. Divatia said respiratory muscle fatigue, so he may have become tired because he's been hyperventilating for a long time. What is the situation recently you've seen this patient? Your respiratory rate is about 33, and is not low. So it's been hyperventilating. In what are the situations will you have a high PCO2? You recently went through a pandemic. Have you seen the blood gas of those patients?
COVID-19.
Yes. Increase in the dead space.
Yes,
Increase
sir.
in the dead space ventilation with
Okay.
Yes, sir. Collapse
All
alveoli. Yes, sir.
Okay, please proceed. So a patient may have something like that, an increased dead space, or patient is fatiguing.
Yes, sir.
Okay.
This was the outside HRCT chest, which was done, which was showing bilateral patchy consolidations. In the emergency room, the patient was being started on the following drugs. He was being started on tablet oseltamivir, on tablet doxycycline, cefparazone plus sulbactam, on hydrocortisone, pantoprazole and heparin. And the patient was being shifted to ICU with the NIV support.
Can I interrupt there? We'll go to the drug list.
Yes, sir.
So what are you covering?
So doxycycline, since he has cough, breathlessness, and fever, so for atypical coverage, doxycycline was started, sir, and cefparazone sulbactam along with cefparazone sulbactam. It was started because he has already received OPD basis treatment and he did not show any improvement, and oseltamivir because of the picture hypoxia, hypercapnia on presentation with such low FiO2, with such low PO2s, and hydrocortisone, he had V's on presentation, sir. So hydrocortisone was started in view of that, and so that's all, sir. Antiviral and antibiotic for the.
All right. So will you consider this as a serious respiratory infection?
Yes, sir.
Yes, sir.
Because his PO2, he has PO2 of
even with 15 liters of Oxygen, his PF ratios are very less. They are 85.
And there is respiratory rate more than 30.
Sure. Okay, we agree that it's severe. So what is the dose for ceftriaxone sulbactam when it comes for a serious infection?
3 grams IVBD followed by 1.5 gram IV, 3 grams stat followed by 1.5 gram IVBD.
Is that correct? I think you need to check up for a serious infection.
I'll check, sir. Sorry.
Okay. All right.
So you mentioned atypical organisms. What are the atypical organisms?
Chlamydia, mycoplasma, Legionella
pneumonia, Legionella pneumophilia.
Yes.
So what does doxycycline, scrub typhus?
Scrub typhus, doxycycline is effective for scrub typhus also, sir. But scrub typhus would present with fever and rash also, rather than cough and breathlessness. Fever would be the presenting symptom for scrub typhus, fever associated with Eschar.
Which antibiotics work best against Legionella and mycoplasma?
Legionella, azithromycin is macrolides are preferable, sir. And one more is this clarithromycin is best for mycoplasma.
Yeah, so macrolides are generally preferred, right?
Macrolides are generally preferred, sir. Yes.
And doxycycline covers the chlamydia better?
Doxycycline covers chlamydia, sir, but azithromycin would also...
which is a chlamydial infection which causes pneumonia?
Chlamydia pneumonia, sir.
No, what is that infection called? Suffer with birds.
Psittacosis, sir.
Because, okay, okay. What is the role of hydrocortisone in severe pneumonia?
Sir, according to the recent trials, hydrocortisone, according to the CAPCOT trial, hydrocortisone when given at 200 mg IV per day improved overall 28-day mortality.
That is the only recent trial which has shown a difference, right? Others have not shown much.
Others have not shown a difference, yes.
What is the... Now, this patient is obviously very sick, okay? Because he's got severely hypoxic in spite of giving so much oxygen. But in general, if the patient was not so hypoxic, just tell me what are the scores for diagnosing severe pneumonia?
CURB 65, sir.
And pneumonia severity index.
Pneumonia severity index.
Tell me in detail.
CURB 65 includes confusion,
blood urea nitrogen, and then
respiratory rate more than 30, systolic blood pressure less than 90 millimeters of mercury, age more than or equal to 65 has 2 points, less than or equal to 65 has 1 point.
Yes.
So more than or equal to 2, patient requires admission, sir. Less than or equal to 1, they can receive OPD basis treatment, sir.
Right. Okay, carry on.
Patient was shifted to AMCU and NIV support with the following settings. FiO2 was 100% and with pressure support of 12 centimeters of water and PEEP of 6 centimeters of water. General physical examination.
Can I interrupt you again? Sorry.
Yes, sir.
Okay, tell me, in a patient like this, what is the role of non-invasive ventilation in patient with severe acute hypoxemic respiratory? Is this ARDS?
Yes, it could be ARDS.
It is ARDS, sir, with recent onset of bilateral infiltrates and PF ratios being on the lower side. It is ARDS.
Can you just go over the definition of ARDS for me?
Yes, sir. So Berlin definition of ARDS describes as acute onset less than 7 days of chest infiltrates which are not explained by collapse, effusion, and nodules, and with PF ratios of less than or equal to 300.
And edema which is not explained by cardiac failure or any fluid overload.
Excellent. And there's one more point in the Berlin definition.
Yes.
that the patient should be receiving?
A peep of more than
five-
5 centimeters of water.
So unless the patient is not at least on NIV, you cannot technically make the academic definition of ARDS. Okay, that's why you just call it acute hypoxemic respiratory failure. Although this is ARDS for all practical purposes, but they need to be on 5 of CPAP or PEEP, right? So which you can make that diagnosis once you put him on NIV. But if you got him on a HFNC or a non-breather, then you what is a Kigali definition, Kigali modification?
Of ARDS, sir. Definition, sir.
So, okay. So this was used in Rwanda, it's in Africa. So the capital is Kigali. So they use this to, because blood gas is not available everywhere, right? So in very resource poor settings,
SF ratio.
SpO2,
SF ratio is very
F ratio, SpO2 to FiO2 ratio, less than 310 or 315. Okay?
Yes.
And they don't require use of PEEP or CPAP because very often they don't have ventilators, and either X-ray or ultrasound signs of infiltrates, right? Alveolar syndrome on the ultrasound. Okay, so that's the sort of, it's called the Kigali modification of the Berlin definition.
Okay.
So what is the role of NIV in acute hypoxemic respiratory failure?
So it helps in like maintaining like oxygenation and also CO2 washout. And the advantages are it will not require any sedation, and it will also prevent any
Alveolar collapse.
prevent any it gives the PEEP also, it gives the splint to the alveoli also, and also the patient is like the hemodynamics also like are not affected with NIV.
So
So in this patient, since PCO2 was very high and he had hypoxia also, initially he was started on NIV support, sir.
okay. Do you know of any trial which compared high flow nasal cannula oxygen to NIV?
Florali trials.
What was the finding of the Florali trial?
They have told that there is no any difference in the mortality compared to NIV, oxygen mask, and HFNC. However, the oxygenation and improved, and also number of ventilator-free days improved in HFNC group of people.
How you've transferred this patient on NIV to your ICU? So how would you titrate NIV on this patient? You're giving pressure support of 12 and PEEP of 6, FiO2 of 1.
Yes, sir.
Is there you want to do some titration before you move the patient to ICU? Is it safe to move somebody like this?
Yes, sir. Like we are giving the FiO2 100%. So, we have attached all the monitors, and then under the monitoring, the patient was being shifted to the AMC.
Your problems are not only hypoxia but also hypercarbia.
Yes, sir.
How will you address that as a non-invasive? He could develop respiratory arrest on your way.
Yes.
So what were your peak pressures in this setting? The question is there room to increase your ventilator support?
Yes, sir. We could have increased the pressure support from 12, sir, and shifted the patient to the AMCs.
What is the safe pressure? How high pressure will you accept on a non-invasive ventilation?
We could increase till 20 to 22, sir, and we could shift the patient.
Okay.
So, Spoorti, let me ask you one more question.
Yes.
This patient was very breathless, right? He was tachypneic.
Yes, sir.
Yeah. And let's say you increase the pressure support to 20.
Yes, sir.
do you think, what do you think could be his transpulmonary pressure? So what, in other words, first, what is transpulmonary pressure and what do you think could be the problem with that?
So transpulmonary pressure is a difference between the alveolar pressure and the pleural pressure, sir.
Very good.
Yes, sir. So the pleural pressure is measured through the esophageal pressure
Manometry.
by manometer.
So you can measure, because we are not doing that routinely, but what do you
Yes,
think is the pleural pressure in someone who's so breathless and tachypneic?
Pleural, usually the pleural pressure, it is a negative pressure only, sir. So during inspiration, it will be from -2 to -5, and during expiration.
You and me.
Sorry, sir.
It's in you and me.
Yes, sir.
-2 in me because I'm asking questions. It's -5 in you because you're answering questions. But what happens in someone who's very breathless, with such a bad pneumonia?
The transpulmonary pressure, like the complaints, it will tell the complaints of, like, it will be very less. It will be towards positive.
No, in inspiration.
Uh,
Breathing like this.
so, sorry.
If you're going like this, it'll be very negative.
Why do patients develop intercostal recessions when they are dyspneic?
Because of the negative transpulmonary pressure.
Negative pleural pressure, yeah. Okay.
Negative.
So your transpulmonary pressure will actually, so if your pressure support is 20 and you're putting minus, and his interpleural pressure say -10 or -15, which it can be when he's breathless, your transpulmonary pressure is 20 minus -15. That is 35, which is actually damaging to the lung.
Yes, sir.
So just again, coming back to the question Dr. Subramani was asking, given a choice, okay, in retrospect, between transferring this patient on plain oxygen with a non-rebreather, with HFNO, with non-invasive ventilation with whatever setting, and intubating the patient, what would have been safest for this patient?
We should have intubated the patient, and we should have shifted the patient.
Okay, so that again depends on your system and the facilities in your emergency department and in your hospital. Okay, but if everything is fine, then sometimes maybe even intubating these patients,
Yes.
transport might be a good option.
Yes.
Okay. Carry on.
General physical examination. A middle-aged male conscious oriented to place and person. Class 1 obesity with BMI of 34.5 kg per meter square. No pallor, icterus, clubbing, lymphadenopathy, cyanosis or pedal edema. Pulse was 132 beats per minute, which was checked in the right radial artery. It was regular, good volume, normal in character, no radial or radiofemoral delay. All the peripheral pulses were well felt. And the blood pressure was 132 by 84 millimeters of mercury, measured in the right arm, supine position. Respiratory rate 36 cycles per minute, thoraco-abdominal type of breathing, and there was a use of accessory muscles of respiration. Temperature was measured in left axilla. It was 101.2 degree Fahrenheit, and saturation was 88% on NIV support. Systemic examination. Respiratory system. Shape of the chest wall was symmetrical. Trachea appeared to be central. Use of accessory muscle of respiration was present. Apical impulse was not visualized due to obesity. Auscultation, harsh vesicular breath sounds all over the lung fields. Bilateral inspiratory crepitations, which were more in right than the left, and polyphonic rhonchi were present. Cardiovascular system, S1, S2 heard, there were no murmurs. Abdominal, soft, non-tender, liver and spleen not palpable, bowel sounds were present. Central nervous system, patient was conscious, oriented, GCS was 15 by 15. Bilateral pupils were 3 mm, reactive to light. Tone in all the limbs was normal, power 5 by 5. Bilateral plantar flexion was present. Our provisional diagnosis is lower respiratory tract infection, bilateral pneumonia, impending respiratory failure. The initial lab values were following. The hemoglobin was 16.5, total count 3,250, platelet counts 1.7 lakhs, serum creatinine 0.6 milligrams per deciliter, serum sodium and potassium 141 by 4.1, LFT was within normal limit, PT-INR was 13.1 and 0.96, D-dimer was 2,216 and procalcitonin 0.6 nanograms per ml.
Hey, can I interrupt here?
Yes, sir.
So what do you infer from the hemoglobin?
So from hemoglobin, we will see if there is any tissue hypoxia.
Since he's a smoker, there is
smoker.
a polycythemia. It's little on higher side, 16.5.
Poly.
Okay, when somebody is acutely sick, what else do you think? Okay,
Like if the anemia is because if the hypoxia is because of any anemia, we'll see
no. Hemo concentration. Okay.
Hemo
yes, sir.
concentration.
Yes,
Right.
sir.
So the second step, you just mentioned total leukocyte count.
Yes, sir.
Yes, sir.
You want a bit more information on that leukocyte count? How will it help?
Total
Infectious.
leukocyte leukopenia is there, sir, which is
Okay.
going more towards viral etiology than bacterial.
Okay.
Hmm.
So in differential count, so in viral pneumonia, is there
We
any
have to
role
check
of
for
differential
lymphocytes.
count?
We have to check for lymphocytes and they will have lymphocytosis, sir. With neutropenia. Neutrophils will be on lower side and lymphocytes will be more. Neutrophil lymphocyte ratio will check, sir.
Okay. Is it neutrophilia and lymphopenia or the other way around?
Sorry, neutrophilia and lymphopenia, sir.
Okay. All right. Also monocytes also, right?
Also monocytes,
So
yes.
those may be important. And in differential, you need to look at for immature cells, nucleated RBCs. So that information will help you to know whether it is going to be a viral or it's a bacterial infection also. Okay. And then why did you do procalcitonin on this patient? What is the recommendation on procalcitonin?
So procalcitonin, according to the studies, like it is not having any role in initiating the antibiotics, but however, in escalating the antibiotics and all, we can take it as a biomarker, sir.
So retrospectively, would you have done procalcitonin or not? If you want evidence-based medicine.
No, sir.
No. Okay.
Yes.
All right. Please carry on. So the other thing is your D-dimer. You said viral pneumonia. You have a D-dimer. You
Yes.
have a high CO2.
Yes, sir.
Can you connect all these 3 points?
Yes, sir.
So what could it be?
COVID. Yeah.
The possibility of COVID is always there.
Yes, sir.
Okay. And this season is COVID. Resurgence of COVID. Okay.
Yes.
Please carry on.
In ICU, next we did is the ultrasound chest, which showed bilateral B profile with the lung sliding present, and dynamic air bronchograms were present in the right upper lobe. There were no pleural effusion. And 2D echo, we checked the IVC, which showed around 1.5 centimeters, less than 50% collapsible. There was good LV function, no any regional wall motion abnormality. But the patient continued to have tachypnea, tachycardia, and he was using accessory muscles of respiration.
So we always look at only LV function. In this particular patient who looks very, very sick,
Yes, sir.
will you do anything else on the echo?
We have
RA.
to check for the right ventricular hypokinesia
RA
and
and
right ventricular size. We have to check
Check
whether
for
it is
dilatation.
dilatation, and we have to check for
Wall.
pulmonary artery, right ventricular systolic pressures and pulmonary arterial pressures. We have to check, sir.
Okay.
because of
all right.
obesity and
Oh, yes.
Okay, please carry on.
ABG, after shifting to the ICU, the ABG was repeated within 1 hour on NIV only, and the patient was in impending. The following was the ABG. The PF ratios were 86, the pH was 7.31, PCO2 60, PO2 was 70, and bicarbs were 26. So the patient was in impending respiratory failure with no response to NIV trial. So the patient was intubated. Sedation and muscle relaxants were continued, and following were the ventilatory settings. FiO2 was 100% and tidal volume 400 and PEEP 14, respiratory rate 32, and IE ratios were 1:2.
Okay, can I interrupt?
yes, sir.
So you have obviously intubated a patient who is severely hypoxic.
Yes, sir.
What are the measures you would take to make it very safe for the patient?
Intubation, sir.
Yeah.
So
And he's in the obese side.
yes,
sir.
sir.
We anticipated difficult airway, sir.
So we did rapid sequence intubation. We did, sir.
Okay.
Yes, sir. We kept all the
What rapid sequence intubation? There are various steps you could have right from the beginning.
yes, sir. We kept all the like difficult intubation trolley bedside ready, sir, and we kept all the drugs ready, and we gave the fluid bolus to the patient, and then we kept the like vasopressors also standby, and then we as
What is standby? Sorry.
Vasopressors,
Vasopressor standby. Okay.
We expected hypotension.
yes, sir.
Okay.
And then
What about-
What drug did you use for induction?
Yes, sir.
yes, sir. So we used for induction we used propofol, sir. Yeah. So we kept the all the drugs ready, and then as the patient was already on NIV support with FiO2 100%, so we continued the oxygenation, and then proper positioning of the patient was done. And after that, the first the arterial tube was been put, and then it was been aspirated, and then and then under first the glycopyrrolate and midazolam was given according to the weight, and then we gave fentanyl 2 mics per kg, and then propofol 2 mg per kg dose we gave, sir. And then once we gave the induction agent, we gave the required pressure, and we did the intubation under direct laryngoscopy with 4-number blade with the
So, did you use muscle relaxant or not?
yes, sir. We used rocuronium as a muscle relaxant.
Why rocuronium?
Sir, for
Why not dexamethasone in this situation?
sir, we could have used scoline also, but we used.
Okay. So most importantly, what would you have in terms of personnel? You mentioned all the drugs, you mentioned all the equipment. Personnel.
Sorry, sir.
Personnel. Doctor. So somebody who is very skilled in airway should be there to intubate.
Yes, sir. The skilled intubation, who is skilled in intubation, the senior doctor,
Right.
was been
So
informed.
what are the technique can you use to continue with the oxygenation during the period of apnea?
What are the? Sorry, sir.
What are the
Okay.
maneuver can you do to maintain the oxygenation during this apneic period?
Yes, so we can do apneic oxygenation, like we can put the patient on nasal prongs and we can give the oxygen.
Nasal prongs or something else?
Jet ventilation.
HFNC.
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 Okay.
Yes, sir. Okay.
Okay.
Mm.
Please
And-
carry on.
Yes, sir.
So, which is Meghana Spoorti,
Yes, sir.
what are the problems with using propofol in such patients?
There will be like risk of hypotension and bradycardia in such patients, sir.
So, are there some better or safer induction agents from the cardiovascular point of view compared to propofol?
Etomidate,
we could have used. Yeah,
we could have
can
used,
use,
sir. But
Etomidate and But what is the problem with etomidate?
Nothing, sir. Etomidate has only this adrenocortical suppression.
But as the patient was
Okay.
hemodynamically
He was
stable,
hemodynamically
so
stable.
we chose propofol, sir.
So, so patient is, you've seen sometimes patients crash after you put in the tube, because sometimes just because they are breathless and they're anxious, their sympathetic drive is very high, they maintain their blood pressure. But once you induce anesthesia and you start positive pressure ventilation, they can crash, and propofol will exaggerate that crash.
Yes, sir.
It doesn't happen in all patients, but it can happen.
Yes.
Okay. So any safer agents? One you said etomidate. Any other agent which you can use?
Ketamine.
Which is ketamine. Okay.
Ketamine we can use.
Okay.
So sometimes ketamine can be unsafe when there is extreme sympathetic activity,
Extreme
like what your
sympathetic,
patient has.
yes, sir.
So you should be
It
careful
can
about that. Also.
further suppress the.
Okay.
Okay.
So now you put some data on the ventilation. Now we are dealing with a very severe ARDS according to my assessment.
Yes.
Yes, sir.
What are the information you need to give me on the ventilator settings?
Yes, sir. We have to do low tidal volume ventilation with the optimal PEEP, sir. So usually the tidal volume will be like 6 ml per kg according to the predicted body weight, sir. For this patient, yes, sir.
So you've told us how much FiO2, tidal volume, and PEEP you're giving. Any other information we need?
P plateau,
PEEP
sir.
plats we should see.
P
And then we
plateau
have to-
should be less than 30 centimeters of water, and we should adjust the tidal volume and respiratory rate to maintain the P plateau less than 30 centimeters of water.
Right.
Yes, sir.
So what is driving pressure?
Driving pressure is tidal volume by static compliance of the lungs, sir. Static compliance is volume delta change in the volume with change in the pressure. So static compliance is tidal volume by P plateau minus PEEP, sir. So driving pressure should be less than 15 centimeters of water, and driving pressure directly correlates with the mortality benefit. More the driving pressures, more the mortality. So we should aim to keep the driving pressure less than 15 centimeters of water.
See, in a stiff lung like this, it may not be possible.
Yes, sir.
It will also tell the functional part of
But you should try and keep it as low as possible.
As low as
So,
possible.
so if you increase the PEEP and the driving pressure goes up, is that a good PEEP setting or a bad setting?
Bad setting, sir.
So any change in PEEP or tidal volume or whatever should actually result in a reduction in whatever is your
low
driving
driving
pressure
low
that you
drive.
start with.
Yes, sir. Yes, sir.
Okay.
So, okay, so with this high respiratory rate, what is the other risk?
With this high, other risk is like there will be acid.
Alkalosis will be there.
Your patient had wheeze according to your presentation.
Yes, sir.
Yes, sir.
Presentation.
Bronchospasm.
So what will happen?
Sir, there will be respiratory muscle fatigue with they can have bronchospasm also, sir.
You will start
Increased
developing
work of breathing.
You will start developing autopsy with this patient.
Autopsy. Yes, sir.
You should be very careful when they are having.
Yeah.
So this patient is obese.
Yes, sir.
Yes, sir.
What will be his pleural pressure?
Once he's sedated and paralyzed.
Sir, positive pressure ventilation will be there, sir. So
Pregnancy and obesity cause an increase in the intra-abdominal pressure, and about 60% of that pressure is transmitted to the pleural space. So
yes,
you may have to work with a higher PEEP for in the baseline itself. So you may be able to allow a bit more room for the plateau pressure. So obesity will increase your intra-abdominal pressure, which in turn will increase your intrapleural pressure also.
Okay, sir.
Okay, sir.
Okay. So how will you calculate the plateau pressure?
On the ventilator, we have to give the inspiratory pause for 5
5
to 10
seconds.
seconds, and then
How much?
5 seconds.
5 seconds.
Mm.
Not 5 seconds.
Okay, sir. So we have to give the inspiratory pause, and then we have to see for the P-plat, sir.
What happens during the plateau pressure?
We will get to know the compliance of the lungs, sir, alveolar compliance, like
No. What happens to flow and pressure during the plateau when you give the inspiratory hold?
and-
You said no, it's static compliance. Why do you say it is static compliance when you give that plateau pressure?
Flow and pressure will remain the same, sir. There won't be any increase in the pressure. Static compliance because
So what is a peak pressure? What do you mean by peak airway pressure or peak inspiratory pressure?
peak airway pressure, it is the resistance offered by the airway to the ventilator during the breath respirations.
Is it only the resistance?
Mm.
So during a volume controlled ventilation, when air flows into the patient, it has to overcome the airway resistance and it has to overcome the compliance, the stiffness of the lung, isn't it?
yes,
Yes.
And that results in the peak pressure.
Yes.
So the peak pressure is influenced by resistance as well as compliance.
Compliance. Okay.
When you give an inspiratory hold, what happens? What happens to the flow rate?
Inspiratory hold, the flow rate will be the same, sir. It won't be changed. It will become zero.
Zero.
Sir.
It'll become 0.
Exactly. Perfect. Exactly. So when you press the inspiratory hold button, what you're doing is you're closing the inspiratory valve in inspiration,
Yes.
right? And then the flow rate becomes
Zero.
zero.
Mm.
But what happens to the pressure in the airway?
It will be increased, sir.
Does it come down to zero?
No,
no,
sir.
So, and is it same as peak pressure or will it be less than the peak pressure? It has gone up to the peak, right?
Yes, sir.
And
P-plat
then
will
it
be
comes
less
to a
than
pressure
the
which we
peak
call as a plateau pressure. So
Yes.
it's slightly less than the,
Then the
peak
peak
pressure.
pressure, sir.
because when the flow rate becomes zero, which element goes away? Resistance or compliance? Which doesn't come into account at all?
Yes, sir.
So, yeah, when the resistive element becomes zero, so there is no resistance, and it is only the inflated lung which is equilibrating with the airway pressure. So that is the plateau pressure.
Yes.
Yes, sir.
So that is the importance of plateau pressure. If it's more than 30, it suggests that there is hyperinflation of the lung and you can get volutron.
Yes.
Yes.
Okay, please carry on.
Vitals post intubation. The heart rate was 124 beats per minute. Blood pressure 122 by 82 millimeters of mercury. SpO2 91% with FiO2 of 100%. And APG after 2 hours of intubation was pH was 7.37 and CO2 was 59, PO2 68.6, bicarbonate 31, and PF ratios were 81. ET cultures, H1N1 and COVID RT-PCR was sent. All the invasive lines like central line and arterial line were secured, and the patient was planned for prone ventilation.
Okay. So, what was the plateau pressure, by the way?
32, sir.
32. So, are you happy with your blood gases?
No, sir. There is still the CO2 is on the higher level only, and the PF ratios are still low, sir. So we are not happy.
So what are the goals of gas exchange goals do you have when you ventilate patients with ARDS?
PCO2 can be permissive hypercapnia, sir. PCO2 can be up to 60 millimeters of mercury, and pH should be maintained between 7.2 to 7.25 pH in permissive hypercapnia, and oxygen is still PO2 is 68.6, sir, and PF ratio is 80. So,
So our target PO2 will be from 50 to 80 millimeters of mercury, and SPO2 target we should keep from 88 to 95.
So you're within your targets, no?
Yes, but the requirement of FiO2 is 100%, sir. So
Granted, granted, but with your FiO2 of 100 and your PEEP settings, whatever you've done, you are within your goals for CO2, for PO2 as well as CO2, right?
yes,
yes.
Yeah. So no, I'm not saying you shouldn't be worried because your FiO2 is 100%, but you've at least achieved your goal of gas exchange.
Yes, sir.
Yeah. Okay.
Before turning them prone, what did you do? Any recruitment maneuver?
Yes, so we did the recruitment maneuver, sir. The patient did not respond to like any maneuver. So
What maneuver did you do?
sir, high PEEP
stepwise recruitment
stepwise maneuver we did, sir, by which the patient did not show any response. So we
What is the evidence of recruitment maneuvers?
They did not show any mortality benefit, but there is improved compliance and respiratory improved oxygenation and respiratory compliance, sir.
Okay, sure.
How do you know that a recruitment maneuver is successful?
By seeing the improvement in the saturation.
Okay, oxidation improves. What else?
Oxygenation and
compliance improves, sir.
Okay, excellent.
Stress index will be less than 1, like by seeing the curves. And
what about the CO2?
Yeah, there will be CO2 like washouts, sir, because more dead space will be reduced. So
correct.
Yes, sir.
Yeah, so it should not increase the dead space. So CO2 should definitely not increase. In fact, it should decrease slightly. Yeah, so all three things, if they happen, then your recruitment maneuver is successful.
Yes.
Like your oxygenation index, like PF ratio or SF ratio, is there an index for ventilation?
Yes, sir. Stress index. By seeing the
Sorry, say it again.
Stress index, sir.
Okay.
By
we are looking at efficiency, how good the oxygenation is, how good the CO2 removal is. Stress index is to see whether your
compliance of
the lung. Yes.
Okay, but this one is for carbon dioxide, like how easy it is to get the oxygen in, similarly how easy it is to get it out, or there's any improvement in the ventilation. Have you heard about ventilatory ratio? There's not many studies on ventilation ratio, but it's slowly coming up.
Yes, sir.
Okay, sir.
To see whether that can be a prognostication like the PF ratio. Okay.
Okay, sir.
Okay, sir. Proning session 1. So the first session of proning was done for 16 hours. Patient was sedated and paralyzed. All the pressure points were secure. No hemodynamic instability was there. RT feeds were started at 40 ml per hour. And the ABG was repeated after 8 hours of proning with a FiO2 of 90%. Following was the ABG, where the PF ratios was 105 and the pH 7.36 and PCO2 48.6 and PO2 95.3, sir.
So this patient was a responder or? Are you happy or not happy with this response?
We are happy, sir. There is increase in
Initial
the 20 mmHg of PF ratios from the supine PF ratio.
So how does prone ventilation work? What are the benefits of prone ventilation?
homogeneous ventilation of the alveoli, sir, and the compression of the heart on the lungs will not be there, and there will be expansion of the lungs will be good, and the alveoli which are completely collapsible and alveoli which are like all the alveoli are recruited and ventilated, and the posterior part of the alveoli are also ventilated. So there will be increased ventilation perfusion.
And there will be
Imagine.
increase in the like better diaphragmatic movement and
Better
clearance of the secretions, and also it will ventilation perfusion, like in the upper zone there will be better perfusion, and in the lower zone there will be better oxygenation. So by which it
So
will
effectively, your compliance should be better because more alveoli are opening up.
Yes, sir.
So you will need lower plateau pressures.
Yes, sir.
If your oxygenation improves, you'll need lesser oxygen,
Yes, sir.
FiO2.
Yes, sir.
And because the lung is more homogeneous, the lung injury will be less, right? So prone positioning not only improves oxygenation, it also improves lung protection.
Yes,
Yes, sir.
And reduces lung injury. So that's a very important mechanism of. So what are the mechanisms of ventilator-induced lung injury? Now that you mentioned, what is stress and what is strain?
Sir, what happens is ventilator-induced lung injury, strain will be alveoli when they are continuously opening and closing of alveoli without any residual volume will result in the shear stress, sir, and it will cause trauma.
Atelic trauma.
It will cause. And one more is due to the pulmonary.
And also because there are three different zones, like there is a it might cause over distension injury also, like if we are if we are applying the PEEP, like in the normal alveoli also the amount of volume delivered will be more, which will result in the over distension. So that is why we are using the low tidal volume ventilations in order to prevent
Okay.
Yes, sir.
Okay, so fine.
Yes.
Okay, but stress, when you say stress in terms of ventilator-induced lung injury, it is a transpulmonary pressure, okay? Which is related to the plateau pressure when the patient is ventilated like this. And strain is the degree of distension of the lung, which is related to tidal volume.
Yes.
Okay. Deformation. You heard the term mechanical power. What is mechanical?
So mechanical
Power.
Mechanical power.
Mechanical power.
So there's an issue with your audio, sir, Dr. Divatia. We can't hear you properly.
Sorry, oh, you can't hear me.
Yes, it's breaking.
Can you hear me now?
Yes, sir.
Yes.
Now can you? So mechanical power is the energy which is imparted when you push air into the lung, right?
Okay.
And that energy can physically damage the lung. It's called ergotrauma.
Okay.
Okay, fine, but that's okay. We can move on. Carry on.
So, I think I need to stop. So you've given information there on the slide 19, yeah? Okay, so you have given information on feeding.
Yes,
Is
sir.
this information you gave me correct?
Yes, sir.
Adequate? Not correct. Adequate?
RT feeds at 40 ml per hour, whether it is adequate or not, sir.
Yes. I need more information.
So we gave trophic feeds, sir, to the patient. So which are like more beneficial when compared to the
Complete enteral
complete
nutrition.
enteral nutrition.
I need, so somebody has a respiratory failure, somebody has problem with CO2 retention.
Yes, sir.
Whether it's, the question is whether it is time to feed. If you feed, what all considerations will you, what all things will you consider when you're feeding this patient?
Actually, the ARDS is the catabolic state, sir, highly. So we have to give the feed to the patient, sir.
Okay.
So
Early enteral nutrition is preferred over IV fluids because enteral nutrition is well tolerated, and since restrictive fluid strategy is beneficial for ARDS, we started on RT feeds, sir. Even though that we started at 40 ml per hour as trophic feed. So
You're not telling me the calories you're giving. How much calories did you give?
yes, sir. We covered
20 to 25 kilocalories. Sorry.
This patient 20 to 25 kilocalories per kg. That is the standard recommendation.
Standard
But
recommendation.
we have to, now we have come to precision medicine here.
Yes, sir.
So here we have a patient who is into the hospital 3 days, has hypercapnic respiratory failure. Will your feeding affect it? Is the question. I understand he's catabolic, all that I understand.
yes, sir.
Yes, sir.
What will be the effect of the feeding on your carbon dioxide?
It will increase the
CO2
CO2 production.
Okay.
Uh,
So you may want to restrict the calories you're giving.
Yes,
You don't want to give.
so
There is no evidence that you need to give 100% of the requirement.
100%. Yes, sir.
So you will reduce the feed, and in fact you may want to delay the feed also.
Yes, sir. Around 400 kilocalories also is sufficient in the initial
trophic feeds we have to make.
Yeah. Okay. So that information you need. Calories is important in this man.
Yes.
Okay. Okay. Please carry on.
On day 2 to 4, total 3 sessions of proning were done. Mechanical ventilation was continued with the PRVC mode and FiO2 of 80% and tidal volume 400 ml and PEEP of 16, respiratory rate 35 and I ratios of 1:2. And following were the ABGs on day 1, day 2 and day 3 of the proning. PF ratios initially improved from 105 to 125. But later on again on day 3, the PF ratios were 109 with the PO2 levels of 87.5 and PCO2 of 56.9.
So here again, you're not given all the information. I would like to see whether we're able to recruit the lungs, what the airway pressures were. All that information is necessary here. And now you're on day 2 to 4. I'll also see what microbiology we've got, etc. But in this mechanical ventilated settings, I would like to see whether there is any improvement in the mechanics.
Yes, sir. The mechanics, like the requirement of the PEEP, like it has increased from 12 to 16, and also the respiratory rate has been increased to 35, sir. And we have switched to PRVC mode of ventilation.
So did you follow the ARDS-NET protocol?
Yes, sir. PEEP according to FiO2 only. According to FiO2, we have selected the PEEP of 16. And tidal volume, we have started with low tidal volume, sir. So 400 ml, 400 ml tidal volume, and IE ratio 1:2.
Okay.
Yes.
All right. And every session is only for 16 hours?
Yes, sir.
Yes,
16 hours.
16 hours, one session was there.
Okay. Okay, please go on.
So on the day 2, 3 and 4, following were the lab values. Chest X-ray showed increase in the bilateral infiltrates, and there was no improvement in the PF ratios also. So that's why the VV ECMO was planned, as the patient did not respond to 3 sessions of prone ventilation. Patient attenders were counseled regarding all the pros and cons of ECMO, and the consent for ECMO initiation was taken. The cardiothoracic surgeon referral was given, and the VV ECMO was initiated by cannulating right femoral and the right IJV with the FiO2 ECMO settings of FiO2 FDO2 of 100% with sweep gas of 6.5 liters per minute and blood flow of 4.5 liters per minute. And the heparin infusion was started with the target of hitting the target of ACT to 180. ACT was repeated second hourly and ABG sixth hourly. Heart feeds were continued at the rate of, sorry.
Tell me, what is the significance of the flow rate of the pump, and what is the significance of the sweep gas flow rate? What does each component do?
Yes, sir. The sweep gas tells us about the CO2 removal, sir, from CO2 removal, and the blood flow, it tells about the oxygenation of the patients, like oxygen.
So what proportion of the cardiac output should the blood flow be usually?
Sir,
Or
in
how?
usually like sweep gas and blood flow, like they should be started at cardiac output like 5 liters per minute only.
So you're assuming the cardiac output of 5 liters, right?
Yes, sir.
So you set it to what proportion of the cardiac output should the blood flow rate be? Should be equal to the cardiac output, some percentage of the cardiac output? Okay. So the better oxidation requires a higher flow rate, isn't it?
Yes, sir. Yeah.
Fine. Okay.
Oh.
Okay, carry on then.
Next slide.
This was the chest X-ray after the placing the ECMO. The ABG before ECMO and after ECMO. So the PF ratios before initiating the ECMO was 109, and after initiating the ECMO, the PF ratios increased to 225, and the pH before ECMO was 10.32, PCO2 56.9, and PO2 87.5, and bicarb were 28. After ECMO, the PCO2 level reduced to 36, and PO2 were 91, and bicarb were 29.4.
So can I interrupt? So did you prognosticate this patient before you put him onto ECMO, and what did you use to prognosticate this patient? How did you prognosticate?
Sir, based upon the
PF ratio, mild, moderate, severe. So 40% mortality with severe ARDS, sir.
Okay.
So we actually did the scoring Murray score, sir. So for this patient, it was more than 3. So we started the ECMO.
Okay. So what were your SOFA scores and your Apache scores? To me, so far, it looks like a single organ failure. Did you do, or you didn't? You don't have the data. Okay.
So this patient was not in shock, right? Did not require vasopressors. Can you hear me?
I think they have, by mistake, they have logged out, sir. They'll let them log in, sir.
Oh, they have logged out. Okay.
And something happened, I think. There is some technical glitch. By that time, we can take 1 or 2 questions, sir, what has been asked. I have answered few of the questions online. So there was a question like regarding the IE ratio in type 2 respiratory failure. Some suggest to keep IE ratio 1:3 or 1:4. Could have been some help in this case because carbon dioxide was not washing out quite well even after day 4 of ventilation.
So, the CO2 removal is influenced by the minute ventilation, right? So the higher or actually more correctly, the alveolar ventilation. So that's a minute ventilation minus the dead space ventilation. Now, if you give a very high minute ventilation, there might be some gas trapping is possible, which is, I think, what Dr. Subramani was hinting at earlier when he asked the question. Now, if there is gas trapping, then your alveoli are over-distended and your dead space may increase, so it will be counterproductive. So you actually either increase the flow rate or you make the I ratio 1:3, 1:4 or something, so you get more time for exhalation. In that way, it will help. But otherwise, the fundamental way in which you clear CO2 is by increasing the minute ventilation.
In this situation where you are in a volume control ventilation and when you want to increase your expiratory time, obviously when you have a fixed IE ratio, obviously your inspirated time will become shorter. That will push your peak pressure much higher because the flow is going to be, within a short period of time. The peak pressures may go up very much, and so that's one thing we need to keep an eye on.
Yeah. But let me put this way, for the same minute ventilation, altering the I ratio will not make a big difference unless it reduces gas trapping if that was present.
Yeah. We are not.
Can I add a small thing, sir, in this?
Yeah, sure.
Yeah. Basically, this is when it comes to ARDS, we believe the time constant to be very low because their resistance is less and your compliance is also low. So compliance into resistance, what we say to be time constant, because the time constant is very low. So they don't require the expiratory time like a COPD patient where time constant is very high.
Exactly.
Because their compliance is also high and their resistance is high. In ARDS patient, even if you do, that is the main reason why we can ventilate these people even with inverse ratio ventilation 2:1, and we believe that they should not retain carbon dioxide. Maybe in ARDS, mostly the issue with the diffusion more than like the expiratory time, which causes the major problem of carbon dioxide retention. And these people, like carbon dioxide is directly maybe proportional to the disease process per se. If the disease is very significant, most of the lobes are involved, they will have more carbon dioxide retention.
Yeah. So that's why in ARDS, you can get away with high respiratory rates of 35, even a little more than that sometimes.
Correct.
The time constants are short.
Your peak
expiratory is low and the resistance is normal.
Yeah, your peak expiratory flow and the expiratory flow, peak expiratory flow will be high and the expiratory flow time will be short in this situation. Yes. I agree with that, but this patient had a bit of spasm when he came. That's why I asked that.
Correct, sir. Yeah. If there is some form of COPD, maybe it makes sense to maybe increase that inspiratory-expiratory ratio. Maybe 1:3 also.
Yeah.
In that case, your inspiratory time will become very short and maybe the peak pressures will go very high.
Correct. So that's the downside of that, but it's okay because the main thing is you should avoid gas trapping because then your CO, if there is high minute ventilation, but your gas is getting trapped and your dead space ventilation is increasing, and that's not good for the gas.
100%, sir. I think they have logged in, sir. They can continue.
Yeah, sorry, sir. There was some technical problem.
No problem. Okay. So where were we? I think Dr. Subramani was asking something, no?
We were on this culture. Now, we are on the slide for culture.
Yes, sir.
ET culture sensitivity was positive for Pseudomonas aeruginosa, and antibiotics were escalated accordingly. Like it was escalated to injection imipenem plus cilastatin was added, and the ceftazidime plus sulbactam was stopped. Bronchoalveolar lavage was done and samples were sent for culture sensitivity and pneumonia filmari panel was sent.
Okay, I'm going to stop you.
Yes, sir.
Read your
Okay.
antibiogram.
So organism isolated was Pseudomonas aeruginosa. Colony count is 100, sir. And sensitive for in cephalosporins.
Okay. No. Colony count. Let's come to this. So do you think this is an infection? This
Sir,
colony.
colony count of more than 10^5 is significant. This is aerobic ET secretion, sir. We got one more report.
No. Based on this one, that is a later one. Based on this one, will you treat that organism?
No, sir.
So what is the commonest organism you can get in patients with bronchiectasis? This patient will have some traction bronchiectasis.
Pseudomonas.
That is the commonest. So we're not surprised by the organism, but I would consider this as a colonizer. Now you're telling me that you have escalated the antibiotic.
Yes, sir.
Why did you have to escalate the antibiotic?
Because of the increase in bilateral chest infiltrates and like oxygenation is also not improved, and so we have escalated, sir.
So based on this antibiogram, you tell me, will you continue the antibiotic or not continue the antibiotic? Leave escalation.
Based on this antibiogram, we'll continue, sir, because of the insignificant colony count.
We will continue. Okay, but all along we thought this may be a viral pneumonia.
Yes, sir.
Okay.
Viral pneumonia, but he's already on ventilator, and he already took antibiotics before coming to the hospital, and with other comorbidities, we would like to continue the antibiotic at this point of time, sir.
If you say evidence-based?
Evidence.
Okay.
So tell me, what is this imipenem and cilastatin? What is cilastatin and why is it there?
Imipenem is beta-lactam. Cilastatin is beta-lactamase inhibitor, sir.
No. Cilastatin is not a beta-lactamase inhibitor.
Sorry, sir.
So imipenem, for the peripheral action of the imipenem, cilastatin has been added, and
What peripheral action? What does cilastatin do?
Sir, imipenem, when it is metabolized, the beta-lactam ring is hydrolyzed. So to prevent that, cilastatin is added, sir.
That's homework for you, huh?
Sir, yes, sir.
Or you can quickly Google it.
Yeah, yes, sir.
Okay. What is the
Imipenem, when it is metabolized, it releases metabolites, sir. Cilastatin inhibits that metabolite.
Because that metabolite is nephrotoxic.
Metabolite is toxic. So cilastatin.
No.
And also.
No. You've not opened the right Google page.
Okay.
So, what is the value of BAL in patient who's already been exposed to days of antibiotics?
Sorry, sir.
So if you're doing a BAL, you said you did a BAL on him, right? For microbiology.
Yes, sir.
So what? How does the presence, when already days of antibiotics have been given, does it confound the interpretation of the bronchoalveolar lavage?
Sir, depends on the sample collection and antibiotic beats in the culture sensitivity media.
No. Again, like you were asked earlier, about the cutoffs. So those cutoffs may not hold if the bug has been partially sensitive to the antibiotic. Then your colony counts or the levels will be on the lower side, right? There are different cutoffs, right? If you're doing a tracheal aspirate, your cutoff is 10 raised to something.
10
if you're doing BAL,
for tracheal aspirate, sir.
Yes. Yes.
10
How much? 10 to the power of?
2, sir.
2 in tracheal aspirate.
What you got is 10 to the power of 2.
Okay. 10 to the power of 10.
No. 10 is also 2. 10 is too much.
10 to the power of 5.
5 in urine and okay, sir.
Okay, for ball,
For ball only, I've said 10 to the power of 2, sir.
no, ball is 10 to the power of 3.
3, okay, sir.
4. Is it not 10 to the power of 4 for ball and 10 to the power of 3 for protected brush?
Protected ball. Okay.
Okay.
5, 4, and
So-
3.
So sometimes, if you're given antibiotics, you may not achieve those cutoffs. If there's been a partial response or something like that. So that's a downside of BAL. So if you see some of the earlier literature, they do BAL very early in the course of the disease. Yeah? Okay. Fine. So what is MIC?
Minimum inhibitory concentration, sir.
Okay. So and what do you mean by breakpoint?
Breakpoint is which prevents the growth of bacteria up to 99.9%, sir.
Can we
Breakpoint
accept
is
that,
determined-
Subramani?
Breakpoint is determined for specific organism and antibiotic pair, which prevents the growth of bacteria by 99.9%.
Yeah, that's right. I'm
Beyond
not sure about the
there is
number.
possibility of
Right?
Sir,
Hmm. Okay. Okay. So, okay. Anyone? I think you can move on from here.
Yeah.
Yes.
Was there any pus cells or any cells in this thing in the specimen that you showed in the microbiology report?
so
Okay,
this
carry
is
on.
a culture sensitivity report, sir. Gram stain, we
Hmm.
did not put it in.
Okay. Hmm.
Yes.
Day 5 to 10. Patient was H1N1 influenza A positive, and the bowel samples were positive for Acinetobacter baumannii, and pneumonia panel was positive for Acinetobacter and Pseudomonas aeruginosa and Escherichia coli. Antibiotics were escalated according to the sensitivity. The TLC count was 11,200.
So, which antibiotics did you give in accordance with the report?
Sir, Acinetobacter baumannii was sensitive only for minocycline and cotrimoxazole, sir. For Pseudomonas aeruginosa, imipenem cilastatin, which was started, was continued, and that's all, sir.
So when you have more than one organism,
Yes, sir.
what thoughts run across your mind?
Gram. Ventilator associated pneumonia, sir.
You have 3 organisms.
Yes, sir.
So how will you treat the 3 organisms?
Uh,
What is the first possibility?
multi-drug resistant pathogen, sir.
It could be a contaminant.
Contaminant.
It's first contaminant. So you have 3 organisms. So now we got a result. How will you go?
Sir, since bowel samples were also positive for Acinetobacter baumannii, we have added a gram-negative coverage, and what?
We identify the pathogen from this. So which is causing all the insult?
Sir, which is causing?
Which of these 3 organisms is responsible for the pneumonia?
Sir, ventilator associated pneumonia, Acinetobacter baumannii is one of the.
No. You have some results. No, next. I think it comes in the next slide. So you'll go by your colony count.
Colony count, yes, sir.
Or if you have something in the blood, you'll go by that organism.
Yes, sir.
Maybe that may be the main pathogen. Okay.
Next.
These were the reports.
That only. Sir, Acinetobacter baumannii colony count is more than 10 power 5, sir.
Okay.
Even in Filamentary pneumonia panel also, the colony count was more than 10 power 5. E. coli, it was 10 power 4, sir.
That's a bowel sample. So is it significant or not significant?
It is significant, sir. So
Okay.
gram-negative coverage we have added.
So what this situation now, what will you call this condition?
Ventilator-associated pneumonia, sir.
Okay, all right.
ACT was checked 4th hourly and titrated the heparin. The target for ACT was 180 to 220. ABG was done every 8th hourly. APTT was monitored 12th hourly. ECMO sweep gas flows were gradually titrated and reduced from 6.5 liters per minute on day 1 of ECMO to 4.5 liters per minute. Patients' PF ratios were around 150. So the lung transplant team referral was given. CT chest was done in view of refractory hypoxemia and difficulty to wean, and bronchoscopy and bronchial toileting was done. Thick mucopurulent secretions were seen in bilateral lower lobes. Bile sample was collected and mucolytic agent was instilled into the tracheobronchial tree. Percutaneous tracheostomy was done in view of prolonged ventilator support on day 9 of the admission. And following the tracheostomy, PF ratios were 185 and pH of 7.3, PCO2 42.9, PO2 73.9, HCO3 22.4, and the following were the mechanical ventilator settings where FiO2 was 40%, tidal volume 400, PEEP of 16, respiratory rate of 30 and IE ratios of 1:2. And ECMO settings where the FdO2 was 100% and blood flow was 4.5 liters per minute and sweep gas flows were 4.5 liters per minute. Following were the lab values on the day 6, 8 and 10.
Sir, can I interrupt, sir?
Yeah, sure.
Yeah, go back to the last slide. Now, do you believe your mechanical ventilator setting is correct when the patient is on ECMO?
Yeah, it's almost like a normal ventilation setting.
Yes, sir.
How you should ventilate a patient when they are on ECMO?
FiO2 should have been more, sir.
What about the tidal volume and respiratory rate?
The tidal volume is appropriate, sir, but the respiratory rate, like based upon the PCO2, we should have gone down, like as already the sweep gas flow is 4.5 liters per minute, so the respiratory rate should have been lessened and titrated with the ECMO.
Usually, what we do when the patient is on ECMO is resting ventilator settings.
Yes,
So there we don't give such high PEEP or respiratory rate and FiO2 also, because the totally patient will be on ECMO, so you will give resting ventilator strategies. We don't give them. Actually, we give around 4 ml tidal volume per kg. FiO2 you can come down to 30 or 40 is okay. Respiratory rate also we come down and we keep it around 8 to 10, so that to keep your alveoli open, not to like, because the patient will be on ECMO, the alveoli should not collapse.
Okay.
Sir, carry on, sir.
So, ECMO, we are using it to improve the gas exchange, but actually ECMO helps also in lung protection because you rest the lung completely. You don't give it that mechanical power from the ventilator, right?
Yes,
Like Dr. Misra said, no, the settings are just rest settings. You are just doing minimal ventilation. So you're actually minimizing or reducing lung injury also because of the ventilator. So it's an excellent lung protective strategy. Yeah, so those normal respiratory settings are not required during ECMO.
Yes. These were the lab values on day 6, 8 and 10. From day 10 to 15, patient showed improvement in the lung mechanics and the chest X-ray. He was conscious and obeying commands. ECMO was weaned and the sweep gas flows were reduced from 4.5 liters per minute to 2.5 liters and then to 0 on the day 15. Patient was monitored overnight with a sweep gas flow of 0. ABG before decannulation with the sweep gas flow of 0 was like PF ratio was 166, pH 7.45, PCO2 49.4, and PO2 100. And the ventilator settings were FiO2 60, tidal volume 400, PEEP 12, and RR 32, and IE ratios were 1:2. And on the day 16, after the patient was kept on sweep gas flow of 0 liters per minute for 17 hours, and the PF with the PF ratios of 166, and the patient was been decannulated.
If the patient is on ECMO, what all the basic thing you will monitor? Apart from your monitoring SCT and other things, what all the basic thing you will monitor when a patient is on ECMO?
We need to monitor if the hemoglobin levels of the patients, and also we need to look for if there is any
Bleeding
from the
side.
cannula side, and also we need to check. We need to check the tubes all the time, and pre-membrane and post-membrane pressures we need to check, and also we need to see if there is any limb ischemia or anything, and
Clots in the
tubes or oxygenate.
What is your pre and post membrane pressure will give you idea? Why we should check pre and post membrane pressures?
We need to check to confirm if the oxygenator is working well, and if the CO2 is properly washed out from the.
How will you know that your membrane is working fine on?
From the CO2 levels, sir.
CO2 levels?
Yes, sir.
Anything else?
CO2 levels and oxygen, PO2.
When you will know that possibility of there is a clotting going on in your oxygenator? When you should suspect?
When the post-membrane CO2 levels are higher.
Divatia sir has told long back, you see, carbon dioxide diffusion happens almost many a times faster than your oxygen. The problem is with the oxygen, not with the carbon dioxide. Diffusion of carbon dioxide doesn't require much of surface also. You require oxygenation is an issue. Anything else regarding the pressure? Can you see directly if there is any thrombus in the oxygenator?
Yes.
Okay. And what is the time frame when you should think of weaning a patient who is on ECMO? That too, in this case, like we have kept a venovenous ECMO.
When the chest X-ray here in this patient, the chest X-ray was showing improvement, and also the patient and also the FDO2, that is the FDO2 levels which were set in the ECMO. So we have to come down by 20%, and then we need to check the PF ratios. So the PO2 levels, if with the reducing FiO2 also, if they are maintaining more than 70 millimeters of mercury, and also we have to come down on the sweep gas flows also, and we have to check the PO2 levels if they are maintaining more than 70 millimeters of mercury, and the patient is the work of breathing and the patient is calm and comfortable, then we can think of
anything else you want to do with the ventilator when you are decreasing your ECMO?
We can slightly increase, like if the, and we should check the PCO2 level. So if the washout of the PCO2 levels is good, then we can think of weaning ECMO. And also meanwhile, we can also increase the mechanical ventilator like FiO2 levels also, and we can wean the ECMOs.
Okay, there are few things missing, I believe. First of all, as you told, your lung mechanics, your compliance has to improve, your X-ray or other mechanics has to improve. Once you believe that the patient may tolerate a decannulation, then slowly you should start decreasing your fresh gas flow. carbon dioxide, as told, is more important. In the meantime, you need to increase your resting ventilator setting, what you have kept. So there you need to ventilate as ARDS net protocol. You need to increase the tidal volume, maybe the respiratory rate and FiO2. In the meantime, you should start decreasing your ECMO flows, and ECMO, more than ECMO flows is the fresh gas flow. Okay, you can decannulate even with a 4 liter of flow. The more important here is fresh gas flow. If your fresh gas flow is switched off, and with your ARDS net ventilation, whatever you are ventilating the patient, if the patient is maintaining a PO2 and carbon dioxide levels for 4 to 6 hours, some people that try for 12 hours, it is like institute to institute, they have difference. If the patient is on ECMO for a very long time, maybe you can try for a longer time before thinking of decannulating this case. Okay, you carry on. And one more important thing, when the patient is on ECMO, in monitoring will be neuromonitoring. When the patient initially will be sedated, you are supposed to monitor neurological status, pupils, and try to decrease your muscle relaxation. They can be a minimal sedation or only analgesia, and always you need to monitor the neurological status, because they can bleed in the brain. That is the most devastating complication of ECMO. Apart from bleeding in any other place, apart from cannula or any other site of the body, brain will be the more dangerous.
What do you mean by recirculation in ECMO? You heard of that problem? You have the venous. What is the position of the venous of the of the two cannula in the? Where are they located?
Sir, the drainage cannula is located in between the inferior vena cava and the right atrium from the femoral artery, and then the other one is located in between the superior vena cava and the right atrium junction, sir. So
It's not artery. We are talking about venous.
sorry, sir. Vein. Sorry. Femoral vein and
Internal jugular.
internal jugular. Yes, sir.
So what happens if the cannula are very close to each other?
So there might be mixing of the blood and.
And how do you identify?
Yes, sir.
How do you rectify?
How do you identify that there is recirculation?
Based upon there will be limb ischemia based on that, and also we have to take the radial artery ABG and we have to see, sir.
All ABGs are taken from radial artery only.
We need to see.
So what are the complications of ECMO? Just quickly tell the complications of ECMO.
Bleeding from the site of the from the cannulas, and also thrombus formation and thromboembolism, and also there might be because of heparin induced thrombocytopenia also might be there, and different.
Suppose you find the hemoglobin dropping consistently after you cannulated
there will be
femoral
lysis of
vessels.
the RBC cells because of the continuous rotation.
Okay.
Yes, sir.
What else could you have? And you also find that the venous pressures are very low, the cannula is collapsing, patient appears hypovolemic.
That is
what do you think could be happening?
Charting of the, that is because of the reduced volumes, blood volume. So that time we need to increase the blood volume, increase the volume either by.
So why is the blood volume dropping like this?
Because of the continuous flow, and there will be continuous filtration of.
Any complication where this bleeding might be taking place?
We need to check, sir, if there is any bleeding. and
Mhm.
and one of the cause might be bleeding, and other cause, like because of the continuous circulation and filtration, there will be reduction in the blood volume. So we need to keep on replacing the volume by giving the blood transfusions or the fluids to the patients.
Basically, whenever we see
Okay.
chattering happens when there is a hypovolemia in the patient. It might be if there is a drop of hemoglobin with hypovolemia, we believe maybe patient is bleeding, or patient if inadequately been resuscitated. Let it be in this case, we are giving less fluid, giving less fluid, and we are giving trophic feed. If they are hypovolemic, in that case also there will be chattering. The chattering happens because the holes of the drainage cannula will be totally will be collapsed on the your intravena cava will collapse on that cannula. So in that case, the suction or the whatever the flow, because the suction pressure or the negative pressure will not happen, that when drainage cannula will start chatter or there will be vibration. That is called chattering. Whenever there is a chattering happening, we believe there is a hypovolemia going on. It may be, as Sir is telling, there might be some bleeding if there is associated with drop of hemoglobin or patient is hypovolemic. In those cases, if there is a drop of hemoglobin, you need to supplement your blood. The target hemoglobin, what we try to keep in ECMO patients will be around 7 to 8, or sometimes they keep 9 to 10 also. If you believe hemoglobin is relatively stable, you need to give fluids. Sometimes they require 500 to 1 liter of fluid boluses also, till you believe the chattering has decreased. Other way, how you can decrease chattering is to decrease your flows. If your flows are very high, as you told initially, you kept a flow of 6.5 liter. There you can have higher chattering chances. If chattering is more, then you need to decrease the flow and give volume. The two things. And regarding what Sir was asking regarding your recirculation. Recirculation happens if your drainage cannula and return cannula is very close to each other. Because the drainage cannula will directly suck the blood which is coming from the return cannula, so there will be no proper oxygenation happening, because that blood only will get circulated. That will not be circulated through your whole body. That is the reason they will have recirculation. Whenever there is a recirculation, there will be hypoxemia. So to prevent it, you need to see every day. We need to do X-ray. You need to measure both the distance between your drainage and return cannula. It has to be maintained around 10 centimeter or more. So if it is less, and you believe over a period of time, there may be some migration also of the cannulas, and more so with the internal jugular. If there is a migration and there is recirculation happening because the distance is less and your PO2 levels are dropping, in that case, you need to think of recirculation and reposition your cannulas. Anything, sir, you want to add? Divatia, sir.
No. Subramani? Dr. Subramani?
Sorry, I'm not familiar with ECMO. It's Greek and Latin to me.
No, anything else at all?
ECMO management, I'm not sure, because I'm not familiar with it.
You please continue.
From day 16 to 25, the patient was conscious, comfortable. Chest X-ray was improving. Mechanical ventilator support was weaned to FiO to 40%, and the antibiotics were de-escalated. Steroids were stopped, and chest and the limb physiotherapy was continued. Patient was mobilized to chair, and the patient was weaned to the AVAP support to thermovent with oxygen support and to the room air. And with the tracheostomy tube in situ, the patient was being shifted to oxygen room on day 18. And the tracheostomy tube was decannulated on day 20. Patient was discharged thereafter.
Okay, so excellent. Did a great job.
Sir, we'll take some questions, sir, which has been asked by our attendees.
Did you have a chance to look at his previous CT X-ray before the current illness? Because he had COVID?
Yeah, no, sir.
You didn't have a chance to have a look at it. Okay.
Yeah, last X-ray.
This was on admission X-ray.
So, So do you call this patient back for follow-up after some time just to see what's happening with him?
Yes,
Yes,
sir.
sir. This X-ray was taken.
Yes, sir. We had called and we followed up. Yes, sir.
You know, because after COVID, a lot of people are talking about long COVID and patients have so many problems after COVID, and but
Yes.
these have been well known even before COVID in patients like this,
Yes.
that they have not only do they have residual lung damage, which hopefully will get better in some time, but they also have a lot of psychological sequelae.
Yes.
They have anxiety, depression,
Insomnia.
extreme cases may have PTSD, insomnia, sleep disturbances, social disturbances, financial disturbance. I'm sure he's had, but that's a different matter. Okay. So ideally,
take
these
some-
patients should have counseling and so. Yeah.
Sorry, sir. Continue, sir.
No, that's it. That's it. We'll take questions.
Yeah, one question was when it is advised to seek option for lung transplants. If
So I have no experience with lung transplant, so maybe you can take that question.
Yes, actually, see, lung transplant in this kind of cases, it is like if your center is equipped with that, because we have the center which is equipped with lung transplant. So we took a consultation of the lung transplant team. It is not always that this patient will require lung transplant, and there is no clarity about when we should think about lung transplant in these cases. At least to be in loop is important, because lung transplant, if you start thinking, then the patient will be in queue. You need to do a lot of investigation before putting that patient in queue for the lung transplant. And whenever there is a lung available, if let's say the patient doesn't improve, in this case, in what they presented, in 18-20 days, it took around 20 days. Few people, they may not respond. After the second CT, if I'm not wrong, done around 10 days of hospitalization was really bad. So if you believe that patient may not recover, in those cases, at least we need to think about lung transplant is one of the getaway thing. Actually, at least to involve them and start whatever require things to evaluate. So it doesn't mean that you need to start evaluate and all those things aggressively at the day 10 of ECMO, but still few people may require lung transplant over a period of time. And there is no clarity about the time frame at what time you should start thinking to involve lung transplant team. But as in this case, they have shown that CT on day 10 was pretty bad. So lung transplant team, if it is there, then it is always better to keep them in loop. So I think the second question was why give high ventilatory setting on ECMO? We have discussed already. And during ECMO, we need to give resting ventilatory settings where we give around 4 to 5 ml per kg predictive body weight tidal volume. We keep the respiratory rate on the lower side, maybe around 10, 12 or 14. We keep a PEEP of around 8 to 10. We try to keep your plateau pressure 30 or less than 30. This is how we need to ventilate. Maybe a volume control, pressure control doesn't make much of difference. At least we'll have the, as sir told, we need to give the best possible rest to the ventilator. Next question was GCS, a patient not seen. It has to be seen, and it is a mandatory thing. Whenever a patient is on ECMO, maybe initial 1 or 2 days we sedate and sometimes paralyze those cases. Afterwards, it has been better to give the minimum possible sedation so that we can always assess their sensorium. Pupils and all is again very important. Those need to be monitored more frequently when the patient is on ECMO and requiring very high systemic heparinization or anticoagulation. And we
So
do. Sir, please, sir.
No. You finished this part. I just had one question after this.
And regarding percutaneous tracheostomy, actually in our center we do most of the ECMO patients also percutaneous tracheostomy, but it is like before thinking of tracheostomy, we have the tool of ultrasound. We can always do and see that how easy it is to do on the bedside. If you see measure blood vessels, or we feel like there is a difficulty in anatomy, in those cases it is always better to go for a surgical tracheostomy, that to bedside. So whenever we are planning for a tracheostomy, we stop heparin for an hour or two. We monitor the ACT. We decrease the ACT maybe around 80 to 90, or we try to decrease. At that point of time, we think of doing that. And usually what like our experience is, the people where we have done percutaneous tracheostomy, they bleed less compared to surgical tracheostomy, post tracheostomy, when you restart your like anticoagulation, whatever need to be given in a patient who is on ECMO. Sir, you're telling something.
So I don't know whether I missed that slide, but was there any fungal tests for fungal infection done? Because about 10% of patients, and it's being little increasingly recognized, get Aspergillus co-infection in these in ARDS. So it's worthwhile doing a galactomannan when they are deteriorating and not improving. So that's another sort of thing that you can think of.
You are unmute yourself, Dr. Meghana. Dr. Meghana, unmute yourself.
Okay, that was just a comment. I mean, it's okay if you. I think if there are any more questions, also we can take.
Sir, fungal culture was done, sir. That report was also there. There was no growth of the. I'll show you the slide.
No.
It's okay.
See,
it's okay. I think what sir was pointing here is these patients where we are suspecting COVID or maybe in influenza, there is a higher chances of fungal infection, more so with Aspergillus. So that has to be kept in mind whenever we are treating this kind of patients who are not responding well to your regular antibiotics and all those things.
And you see fungal, if you see fungal this thing in the sputum, I don't think it has much value. What you need to know is whether it's an invasive aspergillosis. That you'll get from a galactomannan.
Correct, sir. There was a question like measuring the baseline carbon dioxide could had been any use, sir, in this patient, keeping in mind that patient was chain smoker with old COVID pneumonia.
So, there was two things which I didn't like in the presentation. One is that she called him an alcoholic when he take drinks occasionally. So he's not an alcoholic. Okay. The second thing, he drinks 5. He was, if I'm not mistaken, he was taking about 5 cigarettes a day, right? So that doesn't make him a chain smoker.
No.
He's a smoker, all right. So he's at much higher risk of getting some chronic lung disease than someone who doesn't smoke. But like we talked right in the beginning about the blood gas and the interpretation, it doesn't look like he had a baseline CO2 which was high.
Yes, sir.
CO2 went up by 10 and his pH dropped almost by 0.1. So that was almost like an acute drop. And it would have been like a CO2 going from 40 to 50. So from his blood gas, it doesn't look like he was a chronic CO2 retainer.
Correct, sir. What is the indication of starting ECMO in ARDS? Is there any time limit after which ECMO is not advocated?
After 7.
See, so I'll take this question, sir.
Yeah.
Yeah. Regarding ECMO, indications of ECMO. If you see, there are ELSO guidelines. The Caesar trial, they have taken one indication. In ELSO, they have taken one indication. In EOLIA also, the indications are little different. If you see ELSO, first thing they have recommended is the lung involvement should be recoverable or reversible lung injury. And they have seen a Murray score of 3 or more than 3 and PF ratio of less than 100 with proper ARDS ventilation, and the duration of your ventilation should be less than 7 days. They are the few basic things what they have seen in your ELSO guideline. If your PF ratio is persistently less than 150, you should think of ECMO and transfer the patient to ECMO equipped unit. That is what they have told, where the mortality may be more than 50% in the later, but initially I have told where the mortality may be more than 80%. In those cases, you need to start in ECMO. In EOLIA, things are more drastic. Actually, in EOLIA trial, what they have told is, if your PF ratio is less than 80 for 3 hours, less than 50 for 3 hours, less than 80 for 6 to 8 hours.
Less than 80 for 6 hours.
6 hours. In that case, you need to think of ECMO. And regarding the time frame after which ECMO is contraindicated, it's not contraindicated, but after 7 days, the patient may have significant lung injury, and that thing may not improve even after ECMO. So it is like after 7 days, you need to rethink. And if you see the Eolia trial, it is better to start ECMO early than late.
Yeah, I think that is the key, that, if you don't ventilate for 3 weeks and then give ECMO, because by that time lung damage will be irreversible, the ventilator-induced lung damage. So Eolia was designed to show whether early intervention with ECMO would make a difference in survival. Statistically, it was not significant, but otherwise there are 25% difference in survival between the ECMO and non-ECMO. So I think the moment you see that things are not going your way, you should quickly go ahead with prone and ECMO.
Yes.
100%. Sir. In Eolia, the major disadvantage was a lot of patient has a crossover, sir, from
crossover.
Yeah, so that is the biggest problem, because that was the main disadvantage of the study.
But it also shows that if you don't start with ECMO, you quickly cross over to ECMO, you will still have an advantage,
There are a lot of people who have been crossover, they survived.
Yeah,
So
correct.
that was again one more thing where we can take Eolia as a positive trial when it comes to
Exactly.
ECMO patients.
So either you go ahead early, or if you don't go very early, but don't go too late at all. So I think that 1 week is a rough cutoff, but the less time you spend on injurious ventilation, the better the chance on ECMO, like this patient that you presented.
What about APRV in the setting, sir?
APRV, I don't know, because it's a very funny and non-physiological mode. For APRV, it's like a extreme inverse ratio BiPAP, and if you see the inspiration during, you need spontaneous breathing to be maintained if you want to wash out some CO2, because otherwise you won't be able to get adequate CO2 removal. So and I don't know, we've tried APRV in a few patients, but we've always been more uncomfortable than the patient when you watching the patient on APRV. So I know it has been described in some series, but we have tried it, and we've really tried to do it, but we've not been comfortable, and we actually don't do APRV in severe ARDS, including COVID. We did not do APRV, and we just go to the conventional modes of ventilation. So, but if you do APRV, you need to you should not be sedating your patient too much, because you do depend on the patient's spontaneous breathing to have some CO2 washout. And so I'm just assuming you're all familiar with how APRV works, so I won't describe it in great detail. But it's like an inverse ratio BiPAP, where you have about 6:1 or 8:1 sort of inspiration to expiration settings, and expiration occurs in two ways. One is by spontaneous breaths and by the sudden release of airway pressure, and then a quick rise back to the upper BiPAP level. So something like that.
We'll take a last question, sir, because already more than 9 o'clock now. Where should we go for ECOR indication, and how it differs from ECMO? So basically, if you see ECOR, we think of ECOR only when your carbon dioxide is significantly high. With your all possible ventilator strategy, you are not able to wash out carbon dioxide. In those cases, you can try ECOR. ECOR is nothing but again a extracorporeal therapy only. There, we don't because carbon dioxide wash out doesn't require that kind of flow and all. With a normal oxygenator, if you can use that, itself will suffice. And that oxygenator can be used in a ECMO circuit, or it can be used in your dialysis circuit also. And here the requirement of flow is not like 4 or 5 liter. They require 2.5 liter flow also is good enough. So that is what in ECOR is because carbon dioxide diffusion is much faster compared to oxygen. So we can use very less flow, and we can do removal with only an oxygenator adding to your normal dialysis machine also. And ECOR really helps. Actually, we have used in few cases where ECOR help like anything. Anything you want to add, sir? Divatia, sir.
No. So I'll just tell you there was a trial which was done very recently, which was published maybe last year or year before last. They used very low tidal volumes to protect the lung. So they went almost to 4 ml per kilo or less tidal volume. and because of that, the CO2 went up, and they used Accord to wash out CO2. Okay, and one group got normal standard ventilation, one group got this ultra low tidal volume ventilation with Accord. Again, the hypothesis was that very low tidal volume and also on would protect the lung, but unfortunately, this did not produce any difference in outcome. So, having said that, so we can't use this as a routine strategy, but when you're ventilating ARDS patients, like Dr. Misra mentioned, if your oxygenation is not too bad, but it's the CO2 which is giving you a problem, Accord is a very good option. And you can do it with a pump. You can even do it like they used to do it in the old days without a pump, just with arteriovenous sort of flow through the oxygenator.
With like already 2 hours, sir. I think just like that, the time flown away. It was a great discussion, sir. Divatia, sir, and Subramani, sir. Like each and every point we have discussed, I strongly believe that this must be helpful for all the students who are watching, and maybe afterward they will watch the recording sessions in the YouTube and Facebook. Thank you very much, sir, for taking out the time and gracing this occasion. And I will thank Dr. Spoorti and Dr. Meghana to taking out your doing this case in detail and presenting. And thank you everyone for attending.
Yeah, congratulations to Spoorti and Meghana. Not only did they save the patient, but they passed the exam also.
I think you should concentrate on mechanics, the pressures, and that's very important.
Yeah, thank you everyone, sir. Good night, and I will close the session, sir. Thank you.
Thank you.
Thank you. Thank you. Good night.
Yeah.